CMV and toxoplasma can cause neonatal seizure, but intracranial calcification are seen in neuroimaging in both conditions. In addition, symptomatic congenital toxoplasmosis and CMV infection are also typically present with other findings such as jaundice, hepatosplenomegaly, or chorioretinitis. Neonatal bacterial meningitis with group T streptococcus and listeria meningitis can cause fever and seizure. Imaging findings may include cerebral edema, hydrocephalus abscess, but not temporal lobe hemorrhage, which is highly specific for HSV. Sorry? Yes, it's sinusoidal. Because, yes, because we can exclude like cord compression, oligohydramnios, and cord prolapse. These three for late deceleration. No, no, sorry, variable deceleration. Oligohydramnios and cord prolapse for variable deceleration, and intraamniotic infection can come with fetal tachycardia. But in here, it is not fetal tachycardia. It is normal fetal heart rate. And 35, he has passed 35, so no chance of having preterm gest. Maybe preterm, term is 37, but preterm gestation. Okay, fetal blood loss. You are right. Okay, fetal heart rate monitoring. Fetal heart rate monitoring in liver. Fetal heart rate monitoring in liver assesses fetal oxygenation and metabolic status to prevent fetal morbidity and mortality. A category 1 fetal heart rate reassuring has low risk of fetal hypoxemia and acidemia and is managed expectantly. In contrast, category 2 fetal heart rate a category 1 fetal heart rate is reassuring. A low risk of fetal hypoxemia and acidemia is managed expectantly. And in contrast, a category 3 fetal heart rate has increased risk of fetal compromise and require urgent intervention to prevent fetal injury and demise. This patient has a sinusoidal fetal heart rate tracing defined as smooth wave like oscillation rolling fine with fixed amplitude 5 to 15 and frequency 3 to 5 cycle per minute. Sinusoidal tracing are a category 3 tracing are considered ominous because they are associated with severe fetal anemia suggested in these patients with likely fetal blood loss from ruptured vasa previa, bright red amniotic fluid due to rapid fetal exsanguination and deterioration. This patient requires urgent cesarean delivery. So for category 1, we just management expectantly, like reassurance. Is it the management? And for 3 for ABC, 3 for Caesar, CS, cesarean section. CS. Okay. Like think in this way, like ABC is the third letter of the alphabet and category 3. So 3 for Caesar. I know mnemonic is so boring, but I try to remember my. Okay. Yes. You found the first aid 2025. I have sent you in the Telegram. Yes, you can see now. I have sent you like 3 hours ago, maybe before starting. Okay. These sort of things are very easy to found in our country. Yes, all the shortcut things are very easy to found in our country, but it is tough in US. As far I know. Okay. Mm, 6:38. Yes. Only if you develop. No, it is. I will check like 3 to 5 weeks before. So patient can die also. The patient mentions that her niece recently died from neonatal. Her niece. Okay, her niece died. Okay. Yes. I don't know. Can you explain this? I read twice or thrice, but I fail to understand. Who actually died at the end of the visit? The patient mentions that her niece recently died from neonatal group B streptococcus infection after preterm. Okay, her niece may be the baby. Yes. So Streptococcus agalactiae group B streptococcus is a common colonizer in the maternal GIT and genital tract. Although group B streptococcus is typically asymptomatic in pregnant women, it can be vertically transmitted to the neonate during delivery with a rupture of the membrane resulting in early onset neonatal group B streptococcus infection. Uh, Group B streptococcus infection. Maternal colonization with group B streptococcus can be transient, and therefore screening is performed 3 to 5 weeks before the estimated delivery date, which is most accurately predicts the maternal GP status at delivery, because most women deliver by 40 to 42 weeks. Screening at 36 to 38 weeks of gestation by rectovaginal culture. Okay. Pelvic examination shows the right vaginal sidewall defect. Is it trauma? Okay. So this patient with profuse vaginal bleeding after delivery. This patient with profuse vaginal bleeding after delivery and has a postpartum hemorrhage. The most common cause of PPH is uterine atony, insufficient which occur due to insufficient uterine contractility and may be treated with bimanual uterine massage and uterotonic medications. Patients with uterine atony typically have a heavy vaginal bleeding from the cervical os and enlarged boggy uterus palpable above the umbilicus. When the uterus is firm and the fundus is located at the level of the umbilicus, so no uterine atony as in this patient. Evaluation for other causes PPH is required. Therefore, the next step in the management is to inspect the genital tract trauma laceration of the cervix, vagina, perineum, particularly in patients who have undergone operative vaginal delivery, forceps, or vacuum. This patient's vaginal sidewall defect and minimal bleeding from the cervical os. Vaginal sidewall defect and minimal bleeding from the cervical os are consistent with vaginal laceration because the vagina is supplied by the branches of the uterine artery, which receives 30% of maternal cardiac output at delivery. Patients with vaginal laceration can have profuse bleeding, and treatment is with laceration repair. Yes, uterine atony, prolonged labor, chorioamnionitis, and uterine overdistension, multiple fetal macrosomia, and polyhydramnios. Examination is enlarged boggy uterus. Management is bimanual uterine massage and uterotonic medication. And retained product of conception risk factor is succenturiate placenta, manual extraction of placenta, uterine history of previous uterine surgery. Examination is enlarged boggy uterus, placenta missing cotyledons, and retained placental fragments on ultrasonography. Management is manual extraction, genital tract trauma, uh, operative vaginal delivery, laceration of the cervix or vagina, and enlarging hematoma. Laceration repair should be done. An inherited coagulopathy, history of abnormal bleeding in patients or family members, continued bleeding despite contracted uterus, and correction of coagulopathy. She has multiple sexual partners. It is not, I think, that sickle cell related thing, isn't it? Because if, sorry, because he has taken multiple hydrocodone. If it is pain, it would be relieved by this. Okay, don't ignore the sickle cell thing. Sickle cell is very painful. It is getting wrong and wrong. Okay, this patient is this patient at 12 weeks of gestation with abdominal pain is likely having an acute pain episode. Vaso-occlusive pain crisis due to sickle cell disease. Acute pain episodes are more common in pregnancy, likely because increased metabolic demands and hypercoagulable state. Although the incidence of acute pain episodes typically increases with gestational age, They can occur in first trimester. They can occur in first trimester, especially if there are other precipitating factors: stress, nausea, vomiting, dehydration. Acute pain episode can last from hours to days and commonly involve the chest, abdomen, or long bones. Pain occurs due to repetitive red blood cell sickling, which causes microvascular occlusion, decreased perfusion, and tissue ischemia. Abdominal tenderness. Patient report is most reliable diagnostic indicator of an acute pain episode due to sickle cell disease. Episodes are managed with fluid resuscitation and opioid pain control. In addition to being an increased risk for acute pain episodes, patients with sickle cell disease are increased risk for preeclampsia and its sequelae, including placental abruption, fetal growth restriction, and preterm delivery. These patients require more frequent prenatal visit, baseline 24-hour urine collection and protein level testing, and a low dose aspirin for preeclampsia prophylaxis. Yes, yes. Opioid use and pregnancy are risk factor for constipation due to decreased GI motility. However, these patients' pain preceded our hydrocodone use and no change in the bowel pattern are present. And round ligament pain develops when ligament is stretched by the gravid uterus, usually in the late second trimester and third trimester. It typically presents as sharp unilateral pain that radiates to the vagina, is triggered by movement, positional, and resolves without treatment. Constant diffuse abdominal pain at 12 weeks of gestation, unlikely due to round ligament pain. Yes. Okay. Sickle cell disease in pregnancy. Sickle cell disease in pregnancy, baseline 24-hour urine collection or testing for total protein, baseline chemistry level, serial urine culture, pneumococcal vaccination, folic acid supplementation, aspirin, and serial fetal growth ultrasound examination. Obstetric complication: spontaneous abortion, preeclampsia, eclampsia, abruptio placentae, and antepartum bleeding. Fetal complication is fetal growth restriction, oligohydramnios, and preterm birth. wait, cervix is dilated, but there is product is present, isn't it? In the yes, so looks like it is threatening. Threatened, uh, threatened is cervix is dilated, so anytime the product can come out, isn't it? I thought in that way. You can choose your answer. Maybe you are right. Yes, it is not threatened. It is another thing. Yes, it will come out as cervix is dilated. It will come out. I- Open hand. Yes, I missed the word. Threatened is like closer, and it is a next part of the threatened, like inevitable, like cervix is dilated and product will come out at any time. Okay. Spontaneous abortion uh, defined spontaneous abortion defined as unprovoked pregnancy loss at less than 20 weeks of gestation is is a normal case is a normal cause of tar- first trimester bleeding. Spontaneous abortion most commonly results in fetal chromosomal abnormalities but are associated with congenital teratogen exposure and Mullerian uterine septum anomalies. Spontaneous abortion are characterized based on cervical dilatation and the location of the products of conception in relation to the cervix. The patient has lower abdominal pain, vaginal bleeding, a dilated cervix, and a product of conception in the lower uterine segment, a presentation consistent with inevitable abortion. Other ultrasound findings are consistent. Other ultrasound findings of ovarian cyst corpus luteum, and a fluid in the posterior cul-de-sac are the results of the physiologic process of the pregnancy. Treatment options include expectant medical prostaglandin administration or surgical like suction curettage management dependent on patient preference and hemodynamic stability. Yes, yes. I missed the question too. Okay. Okay. Missed. Uh, Missed means no vaginal bleeding, closed cervical os, and no fetal cardiac activity or empty sac. Okay. Threatened is vaginal bleeding. Closed cervical os. Threatened is vaginal bleeding. Closed cervical os, but there is fetal cardiac activity. Inevitable is inevitable again vaginal bleeding, cervical os is dilated, bleeding, os is dilated, cervix is dilated, and product of conception may be seen or felt at or above the cervical os. Incomplete and complete. Incomplete is there is vaginal bleeding, dilated cervical os, and some products of conception expelled and some remain. And complete is vaginal bleeding, closed cervical os, and product of conception completely expelled. Okay, it's non-stress test. Initial maternal awareness for of fetal movement typically occurs at initial maternal awareness of fetal movement initial typically occurs as 16 to 20 weeks of gestation. Maternal monitoring of the fetal movement. Kick counts begins at the third trimester, more than 28 weeks of gestation. Monitoring of fetal movement is a simple method evaluating fetal activity. 1. Limb extension and flexion. Tone, limb flexion and extension. Because normal fetal activity is more than 10 movements in 2 hours, typically indicates normal fetal acid base status and low risk fetal demise. In contrast, uh, hypoxemic or acidemic fetus have reduced fetal activity as a compensatory mechanism to divert blood flow from peripheral tissues to preserve oxygen for CNS. Therefore, of decreased maternal sensation of decreased fetal movement requires further evaluation of fetal status. The best next step is patients with decreased fetal movement is non-stress test, a non-invasive method of tracking fetal heart rate over 20 to 40 minutes. Reactive non-stress test more than 2 acceleration and baseline 110 to 160 per minute and moderate variability are consistent with normal fetal acid base status, and non-reactive non-stress test less than 2 acceleration may indicate fetal hypoxemia and acidemia. Additional antepartum testing biophysical profile is indicated in this patient. Okay. Hemolysis, elevated liver. Anemia, thrombocytopenia, acute kidney injury, fever, neurological deficit. Okay, this patient most likely has hit a life-threatening condition that causes low platelet levels and a paradoxical prothrombotic state. It typically occurs 5 to 10 days after heparin exposure and affects up to 5% of the patient. In those who develop the syndrome, heparin forms a complex with a platelet surface, platelet factor 4, inducing the immune system to produce heat antibody. These antibodies bind to platelet surface, leading to thrombocytopenia. The reticuloendothelial system, largely the spleen, removes the antibody-coated platelet, causing mild to moderate thrombocytopenia, rarely 20,000. And arterial and venous thrombosis, heat antibody activate platelets, resulting in platelet aggregation and the release of procoagulant factor. The risk of thrombus is as high as 50% in untreated heat. This patient with sharp chest pain that worsens with inspiration, inspiration that is pleuritic chest pain, tachypnea, and decreased breath sound over the right lung base, likely has an acute pulmonary embolus due to heat. An embolus in the right lower lobe can cause pain radiating to the epigastrium and right upper quadrant. Management of patient with suspected heat includes immediate discontinuation of all products and initiation of therapeutic anticoagulation with a non-heparin anticoagulant fondaparinux in pregnant patient. Okay. So she has preeclampsia, so we give low dose aspirin. Okay. Preeclampsia is the okay, reading the box first. Knee onset hypertension and proteinuria and or end organ damage at more than 20 weeks of gestation. High risk prior preeclampsia CKD, chronic hypertension prior preeclampsia CKD, chronic hypertension, diabetes, multiple gestation, and autoimmune disease. Moderate risk is obesity, amniotic obesity, advanced maternal age, and nulliparity. Prevention is low dose aspirin at 12 weeks of gestation. Low dose aspirin at 12 weeks of gestation. Preeclampsia is a leading cause of maternal. Preeclampsia is a leading cause of maternal and fetal morbidity and mortality due to increased risk of stroke, placental abruption, And DIC, preeclampsia that results from abnormal vasoconstriction, increase platelet aggregation resulting in placental infarction and ischemia. Patients with predisposing factors such as chronic kidney disease, chronic hypertension, and preeclampsia in a prior pregnancy, particularly with severe feature or at less than 37 weeks of gestation, as these patients are at high risk for developing preeclampsia. In high-risk patients, daily low-dose aspirin is the only therapy proven to decrease the risk of preeclampsia because it inhibits platelet aggregation and helps prevent placental ischemia. It is initiated at 12 to 28 weeks of gestation, but optimally before 16 weeks, then continued daily until delivery. So it is initiated within 12 to 28 weeks, but optimally before. Okay. Next. We should, I think that we should induce the labor, like we should, because this patient has passed the term. Now baby is fully matured, so we need to induce the labor. Maybe CS should not be the answer. Maybe as there is no complication. Okay, late term, that means more than 41 weeks of gestation, and post term more than 42 weeks of gestation. Risk factor is prior post-term pregnancy, nulliparity, uh, obesity, prior post-term pregnancy, nulliparity, obesity, age more than 35, and fetal anomalies, anencephaly. Complication is fetal or neonatal macrosomia, dysmaturity syndrome, oligohydramnios, and demise. Maternal is severe obstetric laceration, cesarean delivery, and PPH. Frequent fetal monitoring, non-stress test, and delivery prior to 43 weeks of gestation. Patients with late term more than 41 weeks of gestation and post term more than 42 weeks of gestation pregnancies are at increased risk for maternal and fetal complications. Maternal complications such as postpartum hemorrhage and perineal laceration are due to increasing fetal growth macrosomia associated with increasing gestational age. Fetal complications are due to age-related placental change infarction, calcification that results in uteroplacental insufficiency, fetal hypoxemia, and possible intrauterine fetal demise. Due to risk of fetal complication, patients with late or post-term pregnancy undergo fetal monitoring with a non-stress test and amniotic fluid volume to evaluate uteroplacental insufficiency. Signs of uteroplacental insufficiency include late deceleration on non-stress test and or oligohydramnios on ultrasound. Single deepest pocket is less than 2 cm. Oligohydramnios occurs due to uteroplacental insufficiency because fetal blood is shunted from the kidney, which produces amniotic fluid to the brain to prevent central nervous system suppression from fetal hypoxemia. In patients with late or post-term pregnancy oligohydramnios on ultrasound or an abnormal non-stress test, immediate delivery is indicated due to risk of intrauterine fetal demise. This patient has a reactive non-stress test and a vertex presentation can therefore undergo an induction of labor. Yes, cesarean delivery is indicated in patients with abnormal fetal heart rate racing, like in late deceleration or fetal malpresentation, breech, neither of which are present. Breech. Okay. 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 Bye bye.